So thanks and welcome back. This is our final panel discussion, and these are the people who have all the answers. So I will introduce them. Now we've actually we've heard a lot from the research contingent, especially this morning, which has been fabulous. And representing them ably on the panel is Dr. Lucie Cluver. So Lucie, if you could raise your hand so people know who you are. So Lucie was very much a big part in phase 1 and phase 2 and in phase 3. In fact, it was her research on the young carer study that we got the data for the model that Chris did. So we're very happy to have Lucie. But the rest of us are basically programmers and funders, or program funders, right? So I'm going to start to our far right with Lisa Bohmer. Lisa joins us from the Hilton Foundation, formerly at Elizabeth Glaser Pediatric AIDS Foundation, and a great partner with us in the early childhood development and all the work that Hilton has been doing. Then we have Kendra Blackett-Dibinga, and Kendra is Director for Child Protection at Save the Children, USA, but it's now Save the Children broadly, and so welcome, Kendra. We have Massimo Zucca, who you just heard all about the SCORE project, and Massimo and his lovely family and kids are all based in Uganda, and it's been, what, 4 years now, or 5 years? Okay, 5 years. We've had a chance to visit his program. We were gonna have Fred Sawamala join us today, but unfortunately he couldn't due to a family illness, but we're really glad that Massimo could step in and give us a little more gender balance on our panel, and in addition to being an expert on the programming side. And last but not least, we have Anita Smith. And Anita is president of the Children's AIDS Fund International, or CAFI, I think you say CAFI. And Anita's organization has been a long-term partner of PEPFAR programming, and so we're really pleased to have her here. And she's also been a great representative of the faith-based community, both in working on our guidance and over the years just on the PEPFAR program. So thank you all for being here. And as I've said, I expect you guys to have all the answers to what we've seen before. Now, actually, we've had a lot of great information today. We had a lot of great research that we discussed in the beginning, and a very interesting model of what we might do forward. And I think what we'd like to do with this time is unpack maybe some of our observations of what we're doing now and what we might do differently, as in more of, less of, et cetera. But I first wanted to get your impressions of the model in terms of whether there was anything surprising or particularly compelling that came out of it that you will take back with you. And I think I'm going to start with, I'll start with Lisa.
Great, thanks so much, and really nice to be here with you all and with many of our partners, including PEPFAR. I mean, I think one thing is it validates the Hilton Foundation strategy, which is great because it's bringing together early childhood and HIV-affected communities, and I love that we're doing the right thing. We benefit by having HSRC, Linda Richter, and Chris Desmond advising us at the Hilton Foundation, which is fantastic, but I'm continually learning and digesting. I think with the model, what I'm taking back is the importance of adherence for women, because we haven't been thinking about that piece. I think we've been looking, and our strategy is all about building caregiver capacity to meet the developmental needs of children. And as much as we strive to be holistic, I don't think we've been thinking as much about adherence, as well as, to Linda's presentation earlier, caregiver well-being, depression, all that as part of a package. So I will definitely take that back.
Excellent. Lucie.
Can I just add in about this very important point about adherence? And it's something we often don't talk about that much, but when we look at the systematic reviews, there was a systematic review about 2 years ago of retention in HIV care. in sub-Saharan Africa. And after 2 years, it was 60%, around 60%, maybe 62%, Scott. But when we look at and that clearly shows that we're seeing a very large drop-off in a very comparatively short amount of time. And not only that, when we look at pediatric and adolescent adherence, as the kids get older, their adherence drops off more and more. And the best study that I've seen of adherence in sub-Saharan Africa had 4 countries in it and showed that at 6 months, adherence was 20%, and at 2 years, adherence was 7% amongst adolescents. If we don't pay attention to adherence, we're not going to, there's absolutely no way that our treatment approaches are going to work. What's really good news, though, is that there are good studies. So Linda Richter and Mark Tomlinson recently published one, and Ashraf Grimwood also published a very similar one, looking at how home-based care and support and particularly mentoring can improve adherence and then knock-on improve child outcomes. So I think that it's a really bad and worrying piece of evidence, but there is also evidence of interventions.
Okay, but I found it particularly interesting on a number of levels. One is the fact that I also did my master's dissertation on a modeling of economic impact of HIV on households, and I always found it extremely useful experiences trying to model situations, because it's a little bit of an exercise at triaging and filtering of all the things that reality throws at us that make it so complicated. Some of the main points in order to get the sort of the bigger picture or some main lines that draw through a complex situation. And it helps us understand. It helps us understand what we understand and understand what we do not understand yet. And so I think it's always an extremely useful intellectual exercise. This model and its conclusions are just as good as the linkages and the feedbacks and the feed-forward and the various parameters are. And I don't know enough the mathematics, the relationships that connect the various parameters and any probabilistic distributions of the populations that have been plugged in there in order to give those projections to make a judgment on that. But the approach that has been used to starting from an extremely complicated situation and trying to draw some main lines, some main parameters, some main aspects, helps us figure out what could be the important hinges in this situation and the secondary ones. And I think it does bring our understanding and our knowledge forward. So in this sense, I really appreciate it. I think that the conclusions on adherence at general population level are good for a model that has that mathematics and that parameters and starts from that position. I would imagine that you would have different elasticity of the final results that you are looking at if you started from a different situation with a concentrated epidemic or with different underlying environmental parameters. And it would not be surprising because life is complicated and the different situations will probably call for different responses, which is the whole point of also, I think that is really the line that connects all the dots of today's work. The extraordinarily interesting presentations that have been made so far all throughout the day point out to the fact that everything is connected to everything else, and it is difficult and it is complicated, and that's why we don't have a standard solution for everything, which seems sort of trivial, but every now and then also useful to face. So it's good, in particular for the underlying intellectual exercise at trying to courageously isolate what are certain main patterns, certain aspects that then you can work on. And I think it's really the whole importance of working on the reality that is at hand. So I think it's an extraordinarily productive exercise, and I thank everybody that has been working on this, because I think they're doing a very good thing, and they actually have pushed me to think a number of things through, which I will not conclude today, but which definitely will help me work hopefully better in the future.
Great, thanks.
Thank you. I too want to say thank you. I mean, today's been an amazing day with all the great data that's been presented, but I would echo, it actually is reinforcing. I don't think there were many surprises for those of us who work in the field, because we've encountered these things over and over and over, but it was good to understand that we really did have a good understanding of what was there, and have the data to really validate our experience and then be able to move toward next steps. On the adherence issue, I will say that was amazing, startling, but we have seen very effective adherence models. And so I think it's important to take a look at those we've seen them in our programs in Uganda and Malawi, often related to treatment buddies, or a FBO that was involved in the program that really was trained to help the families, and we've always been a proponent of family-centered care, so that was also good to hear today how important that is. But there are ways to make this work that really don't take a lot of money and technology. So.
Okay, great. I think that I would like to echo the word validation. I don't think that there was much that was of real surprise necessarily, but I think Chris said it best when in the presentation of the model, he mentioned that even with adherence, the same interventions that are required to ensure adherence are the same interventions that are required to improve the lives of children. And so I think today was kind of a resounding kind of yes for mitigation. It's totally necessary. We need to make sure that mitigation stays on the agenda for the work that we do, because we can't treat our way out of this epidemic, and we need to be able to stop new infections as well. So the more that we can try and bring all of the camps together, I think the better off we would be.
Thanks. I liked, Chris, what he said about the double benefit. So the double benefit is that children have a positive growth and development, and that people who are living with HIV are tested and kept in treatment and healthy. And I'd like to ask you to reflect a little on the programs that you're working in now, and where you're seeing good examples of the double benefit, and where you think we might need to do some work around that. Go ahead.
I'd love to start. Hey. I must say first and foremost that I am here. I work for Save the Children, but I'm also a member of the OVC task force. So I hope I represent all the organizations well in this panel. But there are a couple things that came to mind as I was listening earlier today, and one of them is a recent study that we did in Ivory Coast, which actually was looking at the role of community caregivers in improving adherence, improving testing for HIV, and improving overall the well-being of the households. And I think that was kind of eye-opening for us, because we have been working a lot on systems, really supporting social workers to kind of do the home visits, and I think the panel of the little boy from Uganda, I think he mentioned that as well, the importance of the home visit for being able to, in a sense, help them through these situations, get them to the right services. So I do think that that's really important. Some work funded by the Hilton Foundation. We have done a baseline study so far, but what we're finding is seriously high rates of mental depression amongst women in particular. We're also finding very high rates of gender-based violence. So from this morning to this afternoon, I think there were some definite links there that we need to really look at more carefully. We're finding high rates of divorce as well, and that for the children that we're working with in the younger age group. And so all of these things are impacting the children's growth and development. I think we need to figure out how we get to the services that deal with mental health. We don't have the right training tools necessarily for this at the community level for the programs in which we work, and so something that's simple enough and that can help us address those particular issues. So I think that that's something that we do need to figure out. If mental health is such a big issue, if violence in the home is such a big issue, then how do those social workers become empowered to address this as well?
We'll just hear from Massimo then.
Again, on the programmatic side, the work of today, the effort, the intellectual effort of developing the model and so on and so forth, points and shows, I think, that the single sector project approach is old. Does not. I mean, it's not really. It's more a collection of missed opportunities than in reality paying out in terms of being easier to administer and to manage. We see that everything is connected to everything else, and people and the families are complicated, and they have a lot of needs and a lot of capacities and a lot of things going on, and they're operating in a complex environment. And we see from our experience that when we register an improvement in an area of the life of the beneficiary families, like for instance, I have some slides that I will spare you today, but tomorrow I'm presenting it. We see that there is, there is an improvement in access to food. We see it mirrored in an improvement in terms of reduction of absenteeism from school and or increase in the schooling level, in enrollment level. So if you are interested in obtaining a certain dividend in one side of the complex aspects of life of your beneficiaries or your participants, you may want to operate on another area that contributes. Maybe it does not explain the whole improvement, but it does contribute. It has something to do with that. So it's one additional trigger that otherwise you would not have in your hands if you didn't have a multi-sectoral response at your disposal. So multi-sector. I think that a multi-sectoral approach that is based on the reality of what's going on is probably a superior kind of approach.
Can I argue? The multi-sectoral approach. Yeah. How difficult is this? I mean, this is something we've been discussing and with colleagues at UNICEF and UNDP, been discussing with governments in sub-Saharan Africa. And when we say multi-sectoral to governments in sub-Saharan Africa, the health people look at the Department of Social Development people, with the idea, my God, we're going to have to put our money together. I just think if we're going to talk about it, we have to think very clearly and programmatically about how that can actually happen.
Absolutely
at a national level. We can do, PEPFAR can do it at local level, but at a national level, that's difficult.
But it does not really mean to be doing everything yourself. It does not mean transforming everybody in everythingologists that know everything about every topic, but it is an issue of understanding how you can leverage the various actors, the various resources, the other programs, and bring in all together, because people do not exist along one single dimension of existence. They have a number of needs. They want to eat, they want to go to school, they want to be healthy, they need this and they need that, and more often than not, all these aspects are interrelated. We've seen it in all the presentations in the morning. If you are abused, then you end up having risky behaviors that then you end up influence your economic security, your food, your access to food, and your own parental behavior. And so in order to touch on one aspect, you need to be understanding that all these other things have something to do with it. Then the challenge is, and it is a trade-off, and it is a very important one, I agree with you, and actually it's a point that I've been discussing with the colleagues from the USAID mission, in Uganda. There is a big trade-off in the sense that it becomes much more intensive. It requires competence on many levels, and so there is an ideal, there is a number of trade-offs and a number of tipping points between the amount of skill and capacity that you internalize in a project and the amount that instead you have to leverage through linkages with other services. I mean, we are SCORE is mainly a socioeconomic livelihood empowerment project. We do not do anything clinical. All the clinical connections and the dividends that have to do to the clinical aspects in the lives of our beneficiaries are due to leveraging the partnership and linking with other stakeholders, mapping them out, trying to engage them. Sometimes it works, sometimes it doesn't, because life is complicated and not always goes the way, but more often than not, actually, it goes in a different way from what you like.
I'm very surprised to hear you say that multisectoral doesn't work when it was your research that said cash plus care. So how do we get to cash plus care? Where do those programs come from?
Well, I have to say, Massimo and I agreed we would be less polite than the people in the first panel, but more polite than Jerry Springer.
But
just a little. So I suppose that there's sort of two sides to it. There's the good news and the bad news. And the good news from the work that we've been doing together with colleagues at PEPFAR and UNICEF and Save the Children is that we seem to have more than a double benefit. What we seem to have is a multiplicative benefit of particular combinations of interventions. And we really started off looking at the benefit of cash transfers, not just cash transfers, but school feeding and food gardening, and to say, what benefit do we get from that in HIV risk? And we found in HIV risk, we get benefits really specifically for girls and mainly in the kind of transactional sex and age-desperate sex, the sex that the girls have to have in exchange for money when they're desperately poor. We then started looking wider at what happened when we included psychosocial care. And psychosocial care was particularly positive parenting and parental monitoring and teacher support. And what we got was an enormous benefit. We found that not only for girls did it work, for girls it worked on multiple outcomes, but also for boys. And when we looked beyond, and we've just started to do these analyses, when we looked beyond HIV, we also found reductions in crime for boys, we found reductions in pregnancy for girls, we found reductions in school dropout for boys and for girls. And we're now starting to look at things like governance and democratic views to see whether those change. And so I think there's huge potential for it to work. But I also think that we have to ask ourselves, what is the coverage of our existing programs? Because when we did a national sample of 6,000 children in South Africa, some of the things that we had tried to include as single variables, like home visiting, we had too few children in our sample of 6,000 to improve. It doesn't mean that there aren't fantastic programs happening, but it means that on a random systematic sample, we weren't necessarily picking those up. And that means that we can't just say that our programs are enough. We have to start thinking nationally. We have to start thinking, how do we reach, and I know this sounds so difficult, we have to start thinking, how do we reach every area or every highly affected area? And it's so easy for researchers to say that.
But the point is that it's not only us. I mean, the world that is concerned with these kind of problems is not perimetered in these four walls. We are talking about exploring models that then, and again, if you get enough buy-in, will be able to be scaled at a larger level. Another challenge is the challenge of the sustainability, and I think that here is an extremely important point. Is I think the concurrence on the family approach, because families are there before any project starts. You work with them while the project is going on, and when everybody's going off to the next high-paid job, the families are still there. And so if you manage to actually trigger their capacity and their engagement and their agency, I heard the colleague talking about agency before, then that's something that remains there. And it does, to some degree, in fact, the community. So these are also processes, again, I mean, and also, I mean, we've all been in the business for a while. We know that things are not going to change, particularly in a revolutionary way in the next 5 or 10 years. I mean, we're talking about longer-term processes that are going to transformationally improve the lives of people. But the point is that once the models are recognized, then we escape from the search for the one indicator, for the one perfect indicator for a certain very, very complicated thing, or from the one program action that will solve everybody's problem, and we go back to the point of dealing honestly with the fact that it depends, which is the most frustrating answer that I keep giving to pretty much everybody who asks me a question. But it is really the point. It's a point of...
Lisa, you jump in there.
All right, I'm jumping.
Don't you dare jumping on me.
So just to continue this, I think, you know, to Kendra's point, you know, we're investing in this workforce, a very vulnerable workforce in communities to reach families, and they're often not prepared to deal with all the challenges. And we're also finding a lot of capacity building is needed of this workforce. I mean, we're talking about doing more than going out with simple health education messages. We're talking about really being able to be a counselor at times, be a good listener, connect people via referrals, et cetera. And sustainability there is a challenge, and they're connected to vulnerable government ministries, right, that have fewer resources. So how are we going to address that piece? But the other part of it, I think, is going back to the first 1,000 days and all that we heard this morning about all the reason why we need to be focused there. And we're still finding, as we look across our portfolio, which is birth to 5, that programs typically still are not reaching the youngest children. And we're, you know, they're preschoolers typically. And so we're saying, what about, where's the health sector in this? And, you know, it is, Linda mentioned it earlier, we have PMTCT programs. We have a real opportunity to enhance existing programs. We've got some good tools, Care for Child Development's out there, the Essential Package is there. So I think we're really looking at, we're seeing Zambia, the Ministry of Health, rolling out with UNICEF. Their IMCI program now has Care for Child Development messages around responsive care and stimulation. So there's a lot that we can do. To Anita's point, it doesn't often require a huge infusion of resources.
It's not expensive, yeah.
Right, but it's enhancing the existing, and it does take, I think we're looking at really improving quality.
I'm glad you brought that up, because I think that, you know, when we saw the presentation earlier on attachment and brain development, we have huge, huge programs that are in clinics. And I'm looking at Melissa Kelly right now, who works very much on the early childhood development front. And we are missing huge opportunities to get healthcare personnel involved in early stimulation messages. And to also recognize where there are issues.
And then people often think, well, they're busy, we're going to add another task. PATH in Mozambique piloted this work and found that nurses on the health card, the milestones are there. So nurses' response was, actually, this is part of our job. And it's enhanced. Growth monitoring looks better now. The interactions have improved. So it wasn't the response that we thought we were going to get. Yeah.
The point around the 0 to 3s is really important. I've been in some meetings recently where, you know, I think there's this big drive towards assessment and assessment of, you know, school readiness, for example. And I think that's important, but we're not getting to school. I mean, we're not getting to the retention. We're not getting, you know, so these things actually start younger and younger, and I think that's where we continue to see the big gap. But I think on the donor side and on, you know, our side and programmers and funders, we need to really make sure that we are careful about this drive to just assess, without actually trying to figure out, well, what does that mean at the end of the day? And so I hope that, you know, at the end of this, we also start thinking through, well, what does that mean in meeting these, the younger children? Which platforms can we actually build off of that already do exist. And I think there is a real challenge about health worker workforce. And I do think that if there's a way we could find to, and I've seen it work in South Africa, that a social worker be placed at a health facility so that there's not, so that there's kind of, the continuum of care is in everyone thinks a continuum of care, and it can be within a smaller setting. It doesn't just have to mean from clinic to community to school, et cetera, but within that whole system, we can find ways to make those synergies, and I think we're maybe missing the boat there, and advocacy for governments need to be happening there too.
So I'm going to turn it over to Anita, but before I do, I just want to jump in 1 minute here, because we're talking about the continuum of care, but Linda presented a wonderful pyramid that talks about, at the top of the pyramid, there are going to be fewer, but certainly a population of children and families that need very intensive services. And then, towards the middle of the pyramid, maybe more where we're doing a little bit more, but we're not sure that all of it is on target. And then that population level. And so I want to ask what you guys think about that top pyramid level and how we get there. And I'm going to throw that one to you.
Well, first, if I could just comment.
Sure.
As families will, or have been there and they will always be there, so will faith churches and mosques, et cetera, in the community. They will be there. In terms of sustainability, they have to be a partner, and there are models that have shown people in the faith community can be trained to go out and even administer ART in the rural areas and do so many things you don't have to have healthcare workers to do. And so that needs to be a model if we look forward to a time when resources continue to dwindle. So that, I just wanted to, but I think in response to your question, I would say, we need to focus on the whole. I feel like we've been focusing on pieces, and so as we look at that pyramid, we're looking at pieces, but the whole pyramid is necessary for us to accomplish what we are trying to do. So, and the presentation said, the lower part is pretty much missing, if I'm recalling it correctly. But I think finding partners in the community, as you were talking, the multi-sectoral approach, is doable if we can define what the areas we need, find the resources that already exist, and they do in large measure, and bring them together to accomplish and influence all of our programs. I think part of what we have to do based on what we've learned today is evaluate what we're doing based on the data and the evidence, and not necessarily stop things, but enhance things based on what we know needs to be added.
No, absolutely. And I think one of the things that we saw especially in the phase 1, phase 2, was that there are going to be some children who have multiple adversities, that are just going to need a bit more than a home visit, a bit more than a nurse saying, this is how you interact with your child better. And I think of, in SCORE, for example, you do a very comprehensive family assessment, and you've got, you kind of know which of your families are doing really, in kids, are doing really, really badly, and how they're progressing over time. And I think the question that Linda was putting out there, not the question, but the reflection is that at the tippy top of that pyramid, there may be a smaller number of children who are, and the street kids was a great example, in really bad straits. How do we do that better? Are we doing enough of it? Because it's hard. You want to be at all points of the pyramid. So how do you, and I'll ask you, in your programs, how do you find that you're addressing those kids that are really at the top of the pyramid? and don't respond to savings groups and et cetera?
Well, that's the point. It depends. You have to work on the reality. We do work through a partner in Kampala with children that are living off the street.
Retrack, yeah.
Retrack, yeah. And I mean, if somebody, there may be very well situations where the savings group is too premature and you need to do something else. There is some life-saving situation. There is some catastrophe that is going on. And you need to handle the catastrophe. You may not be in the position to do it yourself, but you need to know if there is somewhere out there, and there may not be, a service provider or a facility or a capacity out there that can handle the catastrophe. I mean, in the case of the street children are traditionally in conflict with the law. So a chunk of them are regularly harassed, beaten, arrested by the police, then they are kept in remand homes, and they never actually get a court date, and some stay years in sort of detention. So some need just very, very urgently a lawyer that just helps them go through the case. Then why they're on the street, and that really depends, and that depends. There's many, many reasons that throw children to live on the street. And the reasons why they are there will influence how you go about. I mean, ultimately, ideally, in the case of street children, but this is just one case. I'm sure that there are also, the children with extreme disabilities or things like that would also have, their own very special sort of pathway that people need to work through. Then it does not mean that we need to have a specialized team of people that handle extreme disability. We just need to know that if you have extreme disability, you need to access a certain set and range of services that are different from the ones of the other beneficiaries or the other people that you may encounter in your life.
So
but
you access
ideally,
that expertise?
Yeah, we map where it is, and we see if we manage to link it. We have seen. We have filtered our school enrollment data just because it was one that we had on the database at the time, and we saw if through time the enrollment had changed for children with disability or for children without a disability, and they were starting from different baselines, and they both increased by more or less same percentage point. Because they had access to this kind of specific services.
The main question for me, though, is are we finding those kids? Our program, we know that they exist, but we are not necessarily finding them. And,
we have a few thousand. We can send you a few to sort of...
Yeah, I mean, they're hidden in a lot of these communities. I'm sorry, they're very hidden. And this is also part of the issue with the 0 to 3s. Like, they are in the homes where they're not accessing the services that are even available. So we're talking about an even smaller number of children that we're potentially finding. And I think if we can crack that nut, how do we get these people out of kind of isolation, out of into services where we can actually, address some of those needs? I think that's part of the challenge that we face.
So, sorry, because we only have a minute left, and I would love to play Jerry Springer for a lot longer, but what I wanted to ask, I wanted to flip it to the other side of that pyramid and that population level of what are the big things that we need to be doing that seem to be working in high prevalence settings that we should be doing more of. And I'm gonna throw that one to Lucie.
Can I ask you, what do you think, Gretchen?
No, because I'm Jerry, and no, I'll tell you what I think. I think that there is really compelling evidence that very basic economic assistance goes a long way in relieving or alleviating a lot of suffering. I really do think that at a population-based level, when you have such extreme poverty as you are dealing with in some of the countries that I'm dealing with, that it's going to be hard to get to the next step if people are stuck in that very, just miserable state of barely making it. And I do not think that that is enough. It's necessary but insufficient, especially for those kids who are the worst off. But it's something that we've seen in Latin America and sub-Saharan Africa, that at a population level, and what Chris was showing, 5% difference in poverty. And you have these huge returns and so many other factors. So while I certainly come at this from an HIV and AIDS perspective, I have to look at that and say, now maybe it's because I'm at the World Bank today, but I have to look at that and say, that's working. We need to not be the only players there, but we need to be a player there. So that would be my answer.
I think Gretchen's absolutely got it, but the evidence also shows that if you can add that in, if you can add in cash and psychosocial care, you get very, very clear returns. And I think we've talked about that, and I think that's been clearly established. But what I want to ask us is, what happens when you flip that around? And I read an excellent book a couple of years ago by Chris Desmond and colleagues at Harvard and Oxford called The Cost of Inaction. And it asked, what happens if we don't do something? And it really, today really made me think about that. And it's very clear that two things will happen if we do not expand economic strengthening, financial support, and psychosocial care, that there will be two inevitable knock-on effects. The first is that among the most vulnerable children, we will see increased HIV infection rates. And the second is that amongst HIV-infected children, we're going to see reduced treatment adherence. And then two things, mortality, and also ongoing infection rates. As their adherence reduces, they become more infectious, just as they become teenagers. So it almost feels like we're sitting with a big red button, and we can make a decision. We can say, we're going to press this button, we're going to take action, we're going to do everything we possibly can to mitigate this, or we can hold back and not press the button. And that, to me, is really where we are. There's increasing evidence on what we need to do. There's absolutely conclusive evidence on what happens if we don't do it.
And to follow that, I think we need to leverage the momentum right now around the Sustainable Development Goals, the acknowledgement of early childhood. I think there's the inequity concerns, so that's an opportunity for us. But I also think back to that bottom of the pyramid, I think it's an equity issue that we know, we have the brain science here to know what a difference some of these simple interventions make, like love, play, stimulation in the earliest years, and we're not sharing that. And I think we need to, I'm looking at a partnership in Tanzania with Made in Africa TV that PACT introduced me to, that has like a creative show called Mini Buzz, and getting, just like Too Small to Fail's doing here, we need to leverage these communication platforms to get the word out to people, so we're not just relying on home visitors, which are terribly important, and health workers.
I mean, I think we also need to be very conscious that, little children become older children, become parents, and et cetera, and caregivers, et cetera. So I think we need to make sure that our approach is not totally one-sided, that we're not just going to the other extreme of let's just focus on adolescence, for example, when, there are a lot of things that should have happened in the earlier years that got them to this point. And so I think the more we can focus on how we address children at the youngest ages before they become adolescents and before they become parents, so that we can stop the cycle. I think this is kind of the challenge that we have. It's not one age group or the other. It's looking at them, how people progress through this disease and through their lives.
Great. Thank you. Any last one sentence of what we must do? Have we missed anything? We must move on and close our session. Thank you so much.